Morning, everybody. You will notice from your agenda that this was to be a joint presentation by myself and Livette Lamb, who is my other half of the DNA in quality improvement in maternity. But unfortunately, and many of you will know Livette, and unfortunately she's had a very close family bereavement, so can't be with us today. So I suppose just to send her all our best wishes. Is my presentation somewhere? What about it? Oh. Sorry. Okay. So I'm here to speak to you this morning, well, I suppose specifically around the maternity collaborative, but really around collaboration in total. And it was really taken by Charlotte's eggs and how, collaboration is so important, that we work closely together whilst maintaining our own professional sort of lines of accountability as well. So the first part of this is really around quality improvement, working together to improve maternity care. And we're very fortunate in Northern Ireland that we have the Northern Ireland Safety Forum, which is part of the Public Health Agency, and we work very closely with them on a number of areas. And the first part of this presentation is really kind of going to speak to what the Safety Forum does, and this would have been Livette's aspect. And any of you who aren't involved in working with the Safety Forum, do get in touch with them, because the work they do for a very small team is absolutely incredible. So quality improvement and working together to improve maternity care. So what is the Safety Forum? So the Safety Forum works collectively with the stakeholders to assist in the drive for improvement in safety and quality in all aspects of health and social care. It helps service providers build and develop their quality improvement capability in line with internationally recognised theory and practice. And I think that's one of the really important aspects of the Quality Improvement Collaborative, the maternity one, is having someone with that great expertise in quality improvement to come on that journey with us through maternity, not necessarily having any in-depth knowledge of what happens within maternity systems. And it facilitates engagement between patients, clients, commissioners and service providers in order to promote safety and quality. And again, I think coming back to but just making sure we keep our eggs fried and not scrambled. So I must also say that most of these slides are Livette's. She's terribly clever with technology. I'm terribly not clever with technology. So I will give my indebtedness to Livette for these. So this is a slide that always amuses me. Everyone everywhere wants things to change, and no one's ever done complaining about how much they want things to change, or we need to do this differently. So who wants change? Everybody. Who wants to change? Oh, well, no, they can change. I'm not going to change. No, my bit's fine. No, we'll do it. We'll change so long as they all change to do it the way I do it. So we've a few less people now who actually want to change. And then who wants to lead the change? Well, there's a mass evacuation, because nobody actually wants to do it. They just want it to happen to them. So the HSC Safety Forum, this is their work programme. As I say, they are a very small team. They have a medical director, 3 patient safety officers and some clerical staff, and they run all of these collaboratives and do lots of other work as well. I will say, and totally unbiased, that the Maternity Care Collaborative is the most successful of all of them, and that is totally unbiased. Okay, I mean, no way am I saying that out of turn, but it is. But they do run collaboratives for unscheduled care, community care, paediatric, mental health, primary care, and for scheduled care as well. So it's a really massive, really kind of covering the whole remit of health and social care. So the improvement framework then is that you get a small group of interested people, and we did start with a very small group of interested people. And then you learn about the different contributions that they make to the service of the system. And then you look and see what is in this system now, what do we need to change? And then look at the ideas on how things might be different. Take people's ideas on board. I can't see that one, and I can't see that one. Sorry. Then it's all about testing these ideas to see, do they actually work? Because sometimes we get it wrong and the ideas that we want to change don't actually work. But if we have improved the service, if we've improved understanding of how things work, then we have more control over what we're doing, and that will all lead to better outcomes for our patients and clients. So that's the improvement framework that we work to. This is a bit of a chaotic slide. For any of you who know anything about Deming, it's a system of profound knowledge. And by the time you get to the bottom of that, you will have profound knowledge of lots of things, and maybe not very much at the same time. But it's very chaotic, but that is the system of profound knowledge and how we get there. So the model for improvement is always the PDSA cycle. We plan what we're going to do, we do it, we study whether what we've done is the right thing to do or not, and then we act it. And we do that in order to make a change. So what are we trying to accomplish? How do we know if it's going to have a change? And what changes can we make that will make that improvement? So we continue with the PDSA cycle until we get it right. And there are a number of methods and tools out there. And again, this is Levette's world and the world that she is constantly in. But it's the repeated use of the PDSA cycle until we get to the outcome that we want to. So the maternity collaborative then. The maternity collaborative started in 2010. It was started at that stage by the Chief Nursing Officer at that stage asked that the Safety Forum would come in to look at some work on CTGs. For those of you who don't know, that's continuous monitoring for a baby in labour and induction of labour. It started very small. It was an uphill struggle to get people to engage, but we kind of got there. And then in 2013, we had a bit of we'd sort of got to the stage where we'd kind of got the engagement, things were starting to move. So we rebranded ourselves as a maternity quality improvement group. And the membership was refreshed. At that stage, we got much more multidisciplinary, multi-professional input into it. And we moved forward from there. And since then, we have come on in leaps and bounds. We've had a number of We've had a number of learning sessions. We've had Michael Robson, who's an obstetrician from Dublin, come up to speak to us. We've had Kath Calderwood, Chief Medical Officer from Scotland, coming over. We've done some focus around stillbirths because our own Chief Medical Officer asked us to do that. We've worked with the Perinatal Institute, who do a lot of work around stillbirths and growth monitoring in pregnancy. And then this year, we have moved out because we have our own particular collaborative is largely midwives and obstetricians, and then we link in with anaesthetists. And then this year we had a combined learning set with the neonatal network, which was a really good sign of moving forward and further collaboration. Mary Hines, who's the Director of Nursing in the Public Health Agency where I work, always says maternity has an advantage because it has a plan. And we do have a plan. We have a strategic context to everything we do because we have our maternity strategy for Northern Ireland, which was launched in 2012, and we continue to work to that. So we have a plan of where we need to get to and what the outcomes should be for mothers and babies moving forward. But that doesn't make it easy. We still reach crossroads all the time. We come to places where we think that we have actually achieved something, and then suddenly the fire starts and life isn't what we thought it was. But so long as we work together on a shared goal, we will get there eventually, and we have done. We have a driver diagram which tells us where we are and where we want to get to, and we continually refresh that and work towards that to make sure that we're getting the right outputs for the mothers and babies in our care. So this is our own regional maternity driver diagram. So the overarching aim of our strategy is to provide high quality, safe maternity care, ensuring the best outcomes for women and their babies for all of Northern Ireland. And I think that's one of the things that's so important about the collaborative. We have 11 maternity units in Northern Ireland, 8 obstetric-led units, 3 standalone midwifery-led units, but all of those units work to the same policies and protocols as much as possible. So our 3 main aims then are effective communication, and that's what one of the really big things around the collaborative has been, is having obstetricians and midwives working together for the same aim and not seemingly on opposite sides of a fence to try and get to the same aim. Normalisation of pregnancy and childbirth, and particularly the normalisation of first pregnancies, because if we can keep that as normal as possible, then we're getting better moving forward. And then safe labour and intrapartum care, so that no baby comes to harm when they're in our care during their labour period. So, and then we have a number of outcomes to try and get to for that. So the plan was that we would just go on a miracle little bicycle ride, and then the reality was we had a number of pitfalls along the way. And that's always the way, and any form of collaboration works that way. So, but that's, we get there and we come back up and we get to the flag at the end of the day. So we've had a number of outcomes. We have an integrated early warning score for maternity. All of Northern Ireland uses it. We have a range of other clinical tools. We have CTG stickers, again, that are used in all of our maternity units. And that's particularly important for the staff, because we have junior midwives, we have student midwives, we have trainee doctors that could be working in one unit on a Sunday evening and working in a different unit on a Monday morning. And it's really important that they're not having to go and learn an entirely new protocol whenever they go somewhere else. So whenever they move from Antrim maternity unit to Craigavon maternity unit, the same tools are there that are available in all of the areas. And this has been really important to us. But if we go back to the, who wants to change slide that we had earlier, everybody wanted to have a regional early warning score, so long as it was their regional early warning score. So don't think that any of this came easily. It has been a struggle at times, but we have got there. We've had lots of meetings actually in this building with robust professional discussions about what way we were going to go with some of these things. We have a regional dashboard where all of the trusts share each other's clinical information, so they can look at them and see, oh, such and such a unit is doing well in that area, and then they communicate with each other to say, well, what are you doing? Are you doing something different? Do we need to be doing that as well? I spoke earlier about Michael Robson. He has a group around caesarean sections and why women would be having caesarean sections. They're now all sharing their Robson information, and again able to compare and contrast and look at other people's data and say, because data is power. And they look at other units' data and say, oh, well, they're doing better, so let's talk about this and bring it to the collaborative. It is essentially a forum where we get work done. Our learning sets have grown and grown and grown and grown, and now we need nearly entire buildings to get the people into them, never mind big enough rooms. One of our latest learning sets, we had 46 obstetricians present at it. There's only about 130 of them in the whole of Northern Ireland. So, that is a remarkable achievement to get that many clinicians into a room. And again, over 100 midwives. Our learning sets are just becoming bigger and bigger and bigger. And people want to be engaged. I think they're now at the stage where they have mature, brave conversations, where if people disagree, they can have that conversation and say, no, I'm not really sure. I was speaking to Bob yesterday and speaking about, we had one learning set recently where we had agreed a protocol. One of the trusts was using this protocol and we had agreed it, and absolutely that was it moving forward. But there was one of the obstetricians in the room that we could see was just not entirely sure. So by the end of the weekend, she had done a huge amount of research, and we actually realised from what she'd done that what we were going to implement wasn't exactly the right way to do it. And so, and the email trail back showed the maturity now of our clinicians within maternity, that they're able to say, no, actually, you're right, that wasn't the right way to do it, we do need to do it this way. And 5 years ago, we wouldn't have had that. So we now have that sort of extra maturity where they're able to discuss things with each other and accept that we might be wrong sometimes. Now, as I say, that's not to say that it's always been easy. That wee bumpy road has been bumpy at times. It has taken time to get to where we are. We are 8 years established, and I would say it's only probably in the last 4 years that we really have had that maturity to be able to have frank discussions. It took a lot of time to build trusts, both between the professions to be able to work together, but I think also between the trusts and the units to be able to work together and say, well, yeah, the way you're doing it's the right way to do it, so we'll adopt that. because sometimes there is a bit of being precious about what you've established and what you've done and not wanting to share that, but now that they do. There are competing priorities, we all know that, and that's been talked about. How do you keep professionalism and quality and safety alive in the pressured world that we all work in, and not getting derailed by setbacks on a daily basis when something doesn't happen the way you do. But actually now we have moved to a stage where that is much less than any of us would have expected, and the challenges have become less and less as we've moved forward. So our successes, we would say, is clinical engagement, professionalism and action, whilst keeping our eggs fried, because that is actually really important. You know, every woman needs a midwife, but a lot of women will need an obstetrician too, and we need to be sure that those women who do, that we are able to hand over the care to them as well. We have a willingness to share our successes, and sometimes sharing successes was every bit as difficult for people as sharing challenges. Challenges are easier to bring to a room because you get a solution from someone else. Sharing your success means you're not necessarily having all the limelight to yourself, and sometimes that was a bigger challenge than others. We do say one way for Northern Ireland as much as possible for all of our maternity units and all of our policies and procedures. And it's owned by the professionals and the organisations. Livette and I are there to support them in whatever way we can, but it's not owned by us, it's owned by the clinical staff, and that's really, really, really important. So how do you build a good... didn't know where that one came from. This is a good slide. Northern Ireland has become, the maternity collaborative within Northern Ireland has been published in a book that was written about health systems improvement across the globe. So we wrote a chapter regarding the maternity collaborative, which is in this book. So it's showing that Northern Ireland, putting Northern Ireland and the maternity collaborative in Northern Ireland onto the map. So tips for a good collaborative: patience. It's not on there, but patience. And that's with a C, not with a T. You need to build strong foundations, and you need to give it time to do that, because people will come at it with a nervousness and maybe a bit of mistrust initially. You need to listen to everybody who's in the room. And, you know, it's really important, because actually and one of the good things about a collaborative as well is it is the core people who are providing care, who are come to the collaborative. We have a very open door policy. This is not just for your heads of midwifery and your consultant obstetricians. We have trainee doctors, we have student midwives have come. We're about to run a collaborative that is particularly for community midwives, to be able to bring their ideas forward to what they want to do, and listening to them, because they're the ones who know exactly what needs to change. And then having the engagement with those who know how to do it. Don't give up at the first hurdle, because it would have been very easy to do that, because there was a lot of times where we struggled. And linking up the system across all of Northern Ireland. And Livette's line would be brilliant, be brief, and then be gone, and let them carry on and do what they need to do. So our maternity collaborative then, it's a safe space. Everyone who comes, nobody feels that anything they're going to say will be frowned upon or laughed at. It's a safe space to share ideas and have courageous conversations about quality improvement, because all of this is about putting the woman, her baby and her family at the centre of maternity care and making that care better for them. It's family centred, as I said. It is forward thinking whilst taking on board, not throwing the baby out with the bathwater, as we in maternity like to use as an analogy. So being sure that what we're doing is the right thing to do and we're not making change just for the sake of it. It has developed really strong clinical leadership within our maternity system, where we know now where the people are who are the go-to people to be able to help us with getting things done. And it is about collaboration, working together, because we are all in this for the one aim, and that's to give every baby the best start in life. Okay, Livette and I are always very happy to take any queries. If there are any midwives in the room that I don't know and haven't been to a maternity collaborative, please come and just contact us and we'll tell you when the next one is, because we love to have as many people in the room as possible. And they're always really good, really interesting days. And you can contact us on Twitter, or that's our email address is there. Thank you very much for listening.